Hey everyone, hopefully you got to see the first portion of our episode on sleep featuring Dr. Steven Scheer. Now, part two, we're going to get into the fixes. Okay, what can you do about it? In particular, what did I try? What worked, what didn't work, and where I'm at today. Please stick around for part two of our episode on sleep on unprocessed sugar. So I don't know if this is a question that can be answered. What's more important then, the quality of the sleep or the quantity of the sleep? I mean, they're both important, obviously, but if you had to pick between the two, can you even do that?
I think I'd be hard put to do that.
Right, okay.
I guess I would probably opt for quality if I could always get 4 hours of really good sleep with enough deep sleep in that.
Okay.
So that, in the course of a lifetime, interesting you mentioned this, the amount of deep sleep peaks at the age of 20.
Okay.
It's between 20 and 25% of a night in a 20-year-old who doesn't have any sleep disorders.
Gotcha.
By the age of 60, you're lucky if you get 10.
Wow.
So it gradually goes down. And so I'm complimenting, if I see a sleep study in a lab where I can really be sure about the true amount of deep sleep, because all these apps that you've got on your wrist and your ring finger and over that tells you have deep sleep, don't believe them.
Okay.
You really can't tell deep sleep without a sleep study in a lab.
Okay.
But of those that I see, if I have somebody, an adult over 60 who has 20% of the night deep sleep, I'm complimenting them, saying you are so lucky. Can you tell me something else about your life? That, I exercise every day.
I want to do what you're doing. Right?
Exactly.
Yeah.
So I'd like to have 20% of my night every night. With
that would be
sleep.
The first priority.
But the quantity is important too.
Right.
So really.
And are there things we can do to try to promote our bodies, our brains getting more deep sleep, or it's kind of out of our hands?
There are a couple of things one can do. One is aerobic exercise.
Okay.
So most of the studies that have been done showing the value of exercise suggest that yes, you can increase the amount of deep sleep, delta wave, brainwave sleep in a night if you're a regular exerciser, like 45 minutes or more 5 times a week of aerobic exercise would be really good.
Good.
A second thing you can do is pharmacologic.
Right.
It's use of trazodone. Trazodone is an antidepressant. It's been around. I'm sure you had, when you were in medical school, they were using trazodone. You and I both.
Absolutely, yeah.
Well, trazodone's been around forever. And so far as we know, knock on wood, I don't have wood here, but knock on wood, trazodone is not probably associated with detrimental effects taken long term.
Okay.
It can increase your deep delta sleep.
Interesting.
Maybe 5%, a little more. And that 5% might make a significant difference for making you feel a better quality of sleep.
Okay. I had tried trazodone years ago, and I was stoned the next day till like 12 o'clock. So I thought, well, maybe I took too much. I don't know, but
it's a side effect.
Yeah, that's the whole point of taking it for sleep, I guess, right?
So the people I suggest who give me that information that they have a stoned effect the next day, which is not uncommon, is to either take it an hour and a half before bedtime.
Okay.
Number one, or cut it down by increments.
Right.
So if you're taking 75, go to 50. If you're taking 50, go to 25. See if that still gives you some benefit, but not feeling tired.
Groggy the next day. Right. Okay. And so we're going to get to sleep supplements and sleep medications in a moment, but snoring. Now, is it pretty much, if you're snoring, you have sleep apnea, or are there people who snore and they don't really have sleep apnea?
So the good question.
Kind of hand in hand.
They're not 100% predictors of the opposite. So I have many patients in my practice who snore, about 20% of 20-year-old men and about 50% of 60-year-old men. For women, it's about 10% less. About 10% of 20-year-old women and about 40% of 60-year-old women snore.
Okay.
But the percentage of people who have apnea is less.
Right.
And the percentage of people who have apnea that is symptomatic, associated with daytime sleepiness, is even less still.
Okay.
So snoring, highest incidence. Second highest would be having apnea, but not necessarily with snoring.
Right.
And the third is snoring and apnea and tired during the day.
Right. The trifecta.
That's right. Big trifecta.
Okay. So while we're talking about sleep apnea, what can one do for it? I mean, I see the commercials where the mattresses, the partner props their partner up, they stop snoring. Does that work if you sleep propped up a little bit?
So that's a very good question, and I'm sorry for all of you who just paid $4,000 for a new mattress. I have so many patients. I said, I wish you'd seen me first.
Right.
On the mattress. You could have saved yourself $3,000 out of the $4,000.
Right.
So elevation of the head helps a little bit for people who have sleep apnea.
Okay.
But the vector of the tongue falling back into the back of the throat only changes a very little bit.
Oh, wow. Okay.
When you elevate the head, unless you're sleeping almost sitting up.
Right. Okay.
As opposed to rolling 90 degrees.
Lay on your side.
So if you lay on your side, that helps significantly more than just slight head elevation.
Okay.
That's number one. Number two, those of you who have purchased thick pillows, forget it, because after about 2 hours, you've rolled away, and that pillow is pushed sideways to your spouse, and you're you can't count on a pillow always being there if it's just attached to the bed and not to you. Then there's the question of what about some of these other things? You're always wanting to resort. The last choice is something that is invasive or attached to your body, like a CPAP.
CPAP machine, right?
So a CPAP, continuous positive airway pressure device, is still what we consider the gold standard for treatment of sleep apnea. Even both obstructive apnea, the throat being blocked, and central apnea, the brain not breathing properly, making you breathe. So CPAP or BiPAP, 2 levels of pressure, is still the best choice. A second best would be a dental appliance that brings the mandible
pull your jaw forward.
That's right. It brings your jaw out, and that in turn brings the tongue away and widens the throat in the back of the area where the large majority of sleep apnea occurs, in the back of the throat. The third option is now a relatively new surgical procedure. The old surgical procedure was a very unpleasant removal of all the tissue in the throat except your tongue, the UPPP.
And it wasn't all that successful.
And it wasn't all that successful, but was it horrendous?
Right? Oh, man.
The surgeon would not see you the second visit. He'd have the nurse go in, and he'd run by the office, the exam room.
They're all complaining and moaning and groaning. Right.
So the patient couldn't see him. But the other surgery now that is done more commonly is the so-called Inspire procedure.
Okay, right.
Whereby an electrical device is implanted in the neck from the collarbone where a switch is all the way up to the nerve, the hypoglossal nerve that makes the tongue stick out.
Right.
And that is essentially a pacemaker for the tongue at night. It's implanted, and it can be removed if you don't like the surgical result. So it's pretty effective for some improvement in the apnea score.
Okay.
But unfortunately, sleep apnea therapy, the best still is CPAP, because that device has been shown to give about a 15 or 20 per hour improvement on average for the sleep apnea score.
Okay.
So an average moderate apnea might be 20 or 25 apneas per hour. For those people, not bad to have an improvement that takes you down to like 5 apneas per hour, which would be considered only mild sleep apnea. But people who have very severe apnea, 60 or 70 apneas per hour, having that surgery brings them down to maybe 30 apneas an hour on average.
That's a lot still, right?
It's still a lot. So it's not really a complete cure for everyone.
Okay, gotcha.
That's my impression from the data I've seen from heart studies.
Right. I had wore a CPAP for a long time, and it worked great. It just took a while to get used to it. But I remember going to the lab for the sleep study, and they hook all these gadgets on you and monitors, and then they say, okay, lay on your back and go to sleep. Well, of course, on your back, you're going to have more apnea. But there's cameras on you and all these gadgets, and there's a person sitting in a booth looking at you. Right. Okay, go to sleep now. It's just kind of nuts. But, okay, good. So we talked about the waking up at 3 a.m., and is it also the same when people say I wake up like every hour and a half, kind of the same thing as the 3 a.m. wake up? Is it the REM, you're getting light and you wake up again, or are there other reasons why you wake up throughout the night? Or is it pretty much all related to that REM cycle?
So there are so many variables. You asked me so many questions there in that one little paragraph. First of all, let me say that there are sleep studies in labs that are outstanding sleep labs,
Right.
Such as a lab I happen to use in Northport,
Okay.
Florida, which is always giving me the best reviews
Oh,
I
nice.
get from my patients. This is a sleep lab that has only been here for a few years in this area, and
Okay.
their outstanding results are because the staff is so user-friendly,
Okay,
and the
good.
facility is like a house. It's like your
okay.
bedroom
Right.
in a house.
Not too clinical feeling.
That's right.
Okay.
So one of the problems with being tested in a hospital is the obvious relatedness of the hospital environment.
Right.
For example, there's one hospital in I won't mention which one, in the metropolitan area of Sarasota,
Okay.
where the sleep lab is immediately next to the pharmacy of
Okay.
the hospital.
Okay.
So you can imagine
24 hours a
what
day.
it's like
Right.
to have people sleeping in a sleep lab and next door.
Right.
For a second reason, in a hospital, there are ambulances coming in and out all the time.
Right.
So there are noise disturbances for that. And thirdly, it's just the idea of being in a hospital
Right.
is very unsettling for a lot of people.
Sure.
So
Absolutely.
sleep environment is very important. Now, sleep lab personnel are supposed to have you sleep at least part of the time on the back, just because that is the worst position to
Right.
sleep, as I alluded to earlier with the position of sleep you asked me about in a bed.
Right.
But also, they're supposed to allow you to sleep where you feel the most comfortable
Right.
on your side and encourage you to do that and make all the equipment conducive to that.
Right.
And that doesn't always happen in
Okay.
some places. Now, I should mention there is home testing for sleep evaluation in some people. It doesn't show all the different sleep disorders to have home testing.
Okay.
We can discuss in a second what all the different sleep disorders are that I see in my office.
That'd be great.
But when I'm sending somebody to a lab, I want to see not only how they breathe,
Right.
but what does the EKG do during the night while they're
Sure.
sleeping?
Of course. Yeah.
What do their legs do?
Mhm.
They have restless legs that wake them up. Do they clench the teeth in the course of a night? That wakes them up.
Okay.
Bruxism, teeth clenching, is a reason for sleep
Oh, wow. Okay.
awakenings. And what stages of sleep do they get? I can't see in a home test the stages of sleep,
Okay.
but in a lab test, I can see REM, deep,
Ah.
shallow, all the different stages of sleep, and find out what is the interruption in sleep that is what's causing it.
Okay.
So it could be breathing, but it could be other things
Gotcha.
too.
So to see those stages, you really have to have like some type of monitoring of the brain waves,
That's
right?
correct.
Okay.
That's right.
So all these, like my watch and my Oura Ring, and they tell me what stages I was in for how long.
Okay.
They're really not on the
Okay,
point.
so
then.
let me mention about that.
Yeah.
That's really important because now increasingly people are asking me in the office what good is. I
Right.
have this $4,000 watch I can buy, or this $100
Right.
that my daughter wants to buy me for my birthday.
Right.
And I say, is it after 2020? Because the devices got better, the technology improved significantly after 2020.
Okay.
Interestingly, number one. Number two, assuming it's been purchased most recently
Right.
with the newer technology, you can probably count on the total sleep time.
Mm-hmm.
It's pretty good because now for many decades we've had actigraphy measurements, which is a wrist-related device or a finger device that shows movement or the lack of movement and correlates that with sleeping or not sleeping.
Okay.
Most of the time when people are not sleeping, they're moving, they're fidgeting, they're changing their body position, and it's evident.
Right.
There's also a slowing down of the heart rate that occurs
Okay.
that can be measured from your wrist or your finger
Right.
as you fall asleep.
Mm-hmm.
And that is evident on a heart rate monitor.
Okay.
So we generally can tell sleep onset and
Right.
total sleep duration pretty well from those
Okay. Good.
devices.
Good.
Deep sleep, don't
Not so
count.
much, right? Yeah. Right.
And REM sleep actually does cause a variability of heart rate that is sometimes in certain more sophisticated devices evident.
Huh.
So sometimes REM sleep can be
Okay,
determined.
okay.
But don't go for the deep sleep
right.
measurements.
So I shouldn't get so hung up on what stages it's telling me, and just more the total amount of sleep and the
right.
onset.
And why is that good? Because I have people with insomnia
Right.
who come to me and they insist they're sleeping 1 hour or 2 hours. 3 hours.
Right.
And I'll say, well, what does your
Yeah. tracker
Apple
said,
Watch
right.
tell you? Well, my Apple Watch says 4 hours. And I said, well, you probably are sleeping more than you think.
Right.
So a lot of people have insomnia because of either depression or anxiety or various reasons,
Right.
will underestimate the actual amount of time they sleep. They'll get cat naps. Maybe it's not the greatest depth and quality of sleep
Right.
long term over the course of a night, but they probably do get more sleep than they think.
Okay.
And sometimes that watch can help to know that.
All right. So what about the not being able to fall asleep? Because that's different, or is it different? Is it all one part of the same?
Okay, so now you're getting into the categories of insomnia.
Right.
Now, insomnia is not a diagnosis, it's a condition, a symptom.
Okay.
And insomnia means inadequate falling asleep or inadequate staying asleep,
Right.
along with functional limitations the next day. So it used to be they just defined insomnia as, do you fall asleep or do you stay asleep? Okay, yes or no. But they've added this additional important criterion, which is, do you function pretty well anyway?
Right.
Okay? So with that in mind, with a large number of people who have insomnia, which is very interesting, it varies over the course of the lifetime. Both men and women before the age of 40, it's about 15% of men and women who have insomnia.
Okay.
With that symptom complex I just described, either falling asleep or staying asleep, plus functional problems. After the age of 50, women have gone through menopause, most of them,
Right.
and by the age of 60, 40% of women have
trouble.
insomnia,
Oh, wow.
and it's still only about 15% of men.
Okay.
Believe it or not, so it triples
Wow,
the
that's a
incidence
big
of
difference.
insomnia in women.
Right.
So there are
Wow.
hormonal reasons for that. Women have lost their estrogens, which are respiratory stimulating. So when you lose that, you start increasing the incidence of sleep apnea in women.
Oh, wow.
And by the age of 60, they have almost the same frequency, not quite as high as men, in the incidence of
Wow.
sleep apnea.
I never knew that. That's interesting.
Yes, they increase considerably.
Okay.
And the other issue is the progesterones that are the second half of the cycle hormone for women are calming.
Mm-hmm.
So it's why some people who are into prescribing hormones for women are prescribing progesterones after menopause
Really?
to calm them.
Okay.
And it is supposed to help with the second half of the cycle deprivation of progesterone to get some type of supplement. But women who don't take progesterones, and even some who do, still have anxiety problems that may intensify
Right,
after menopause that make them have trouble with getting back to
That
sleep.
is interesting. I had never heard that before. Very interesting. All right, awesome. Well, how about we briefly touched on sleeping pills and things like that. What are your thoughts on sleeping pills, and are they all the same? Do they work differently? And
Very interesting issue, and it's an evolving issue, because if you asked me that question 6 months ago, I'd have to give you a different answer
Really?
today.
oh wow,
So up until several years ago, Ambien, temazepam, that's
Right.
Restoril, amitriptyline, tricyclic antidepressants, a lot of medicines were being used for sleep that now we've realized have ultimately developed concerns regarding long-term cognitive dysfunction.
oh gosh, okay,
There's increased risk for developing cognitive changes
Right.
in the Z drugs, which is zolpidem, zaloplan, and
Okay.
zapiclone. Those are all,
Zolpidem is that
Ambien.
Ambien? Right, okay.
Zaloplan is Sonata,
Okay.
and azapiclone is Lunesta.
Oh wow.
Yep.
So long-term use of those, there's been a correlation
Unfortunately,
with cognitive decline.
correlated with chance increased risk.
Okay.
Whereas in the average 65-year-old person has about a 1% chance of having Alzheimer's, and by the age of 85, it's about a 20% chance.
Okay.
In all the non-users of sleep
Okay,
supplements,
right.
those who started those drugs that I was just describing, the Z drugs, it's about a 1.5% cumulative risk every year after 65 instead of a 1% risk
Okay.
increase. It's a cumulative risk.
Right.
So maybe we're talking about, this is just a ballpark guess, 30% instead of 20% by
That's
the
a
age.
big difference.
That's a big difference.
50%
If you're 80
increase.
years old and
Yeah,
you want
right.
to live till I'll be 100, now you
Right.
can probably count on it, but your brain is not intact.
Right,
Not
right.
so happy
Not so fun.
of life.
Okay. Are there any prescription medications
Okay,
that are
so
okay?
you want to know, well, what
Yeah.
can you take?
Right.
Please, doctor.
Yeah,
tell me
right,
what.
right.
Okay. So I'm still having in my practice those who take, at least initially to start them, to get them off those drugs I just talked about, using melatonin
Right, okay.
in higher doses than what is generally recommended. Now I have been concerned about ongoing, continuing use of melatonin.
Right.
And I've just now started recommending for those people who are still using long-term higher dose melatonin to get switched.
Okay.
Trazodone is one of those things
Right.
that I'm encouraging, and I'm allowing,
Mm-hmm.
because we don't have, knock on wood, the concern about its development, leading to the development of cognitive change yet.
Right.
And there's a new category, relatively new category, of orexin receptor antagonists.
Okay.
That's the drugs like Belsamra
Mm-hmm.
and Quivivik.
Okay.
These are drugs that inhibit the receptor of orexin. Orexin is a wakefulness promoting agent
Okay.
that is in decline and is lost in narcolepsy patients. So out of narcolepsy research came the awareness
Oh, wow.
that if you can inhibit the receptor of orexin in the brain, it's a natural way of increasing your ability
Okay.
to fall asleep.
Makes sense.
And that, so far as we know, is not causing long-term accumulation of
nice.
risk of
Okay.
cognitive change.
Well, what about the non-pharmaceuticals and supplements? Are there anything? Because, for example, I take glycine and magnesium glycinate before bed in a certain amount, and I've got a AG1, the greens powder drinks people make. They have an AGZ powder they started making now. It's got L-theanine in it and a bunch of different, chamomile and things like that. Any of those really make a difference?
And you're probably going to throw into the maybe we would throw into the mix the THC type derivative.
Yep, CBN, I think it is the one.
CBD oil.
Yeah, yep.
Yeah. So there's only one of those agents that I know of that's been well researched and definitely with controlled trials appears to be beneficial, which is valerian root.
Okay, yep.
And you do find valerian root commonly listed as ingredients.
It's in this combo I take, right? Yeah.
Often it does have melatonin. Often it does have L-theanine or hops and lemon balm.
Right.
These are other agents. And ashwagandha may be listed.
Yep.
And unfortunately, we don't really have, to my knowledge, good randomized controlled trials
Right. Okay.
to really be
okay.
able to recommend and say with certainty
that it's going to help.
that it's going to help
Right, okay.
and it is long-term benefit. I get all kinds of anecdotal phone calls from patients.
Right.
Oh, I can tell you, doctor, you can tell the rest of your patients that my Relaxium really works for me.
Right, right.
People tell me that, and maybe two people in the same day, and I'll start to wonder if maybe that's when I should recommend, but I can't be sure
Right.
that it's been tested.
All right. We briefly mentioned it earlier about movement. That's different than restless leg syndrome. People have their legs just. What's that? What exactly?
Let me mention,
yeah, please.
before I do, one more thing about melatonin, because I still do have patients, quite a few, who take melatonin, and some in higher doses at my recommendation.
Mm-hmm.
And recently, a very important abstract, not an actual randomized controlled trial, but an abstract came out making it a concern that now a lot of cardiologists have jumped on the bandwagon of. The concern that was raised was that long-term use of melatonin can lead to a greater risk of congestive heart failure in a percentage of patients.
That's pretty
It's
crazy.
not a huge increase in risk, but it is an increase in risk, according to this single abstract. I think that the subject of melatonin really needs to be researched further for us to know with certainty about it, because it is available and it is something that people are going to take. It's over the counter in this country still.
Right.
So we really need a lot more research to be done on melatonin. Now, in regards to your question about restless legs, it's interesting that dopamine, which is a neurotransmitter in the brain, is involved in various circuits that are on a circadian rhythm.
Right.
These circuits that are involved with dopamine in the brain are less active at night and make restless legs a condition that tends to evolve in people in the nighttime at first.
Right.
As the condition gets worse, they may have it earlier in the day. This condition of dopamine is one of the reasons that we use a dopamine medication called Mirapex or Requip to treat people who have restless legs, and it works very well. It even works in people who have restless legs while they sleep at night.
Okay.
One of the 88 sleep disorders that are in the book.
Most doctors find that there's a 3, 4, 5 different diagnoses that make up 90% of their practice. Do you find that to be the case with sleep medicine?
Absolutely. It's very interesting. When I first decided that I wanted to study the field of sleep medicine, I thought I knew that I would be dealing a lot with sleep breathing, but I
Right.
was not aware there are 88 different diagnoses
Oh my gosh.
in the field of sleep medicine that are officially recognized by the International Classification of Sleep Disorders
Okay.
book that has our disorders. But about 7 things, I would say, characterize 99%
Most of it. Okay.
of what I see. The common biggest one is respiratory. About
Right.
2/3 of the people who come to me have either a sleep breathing disturbance or snoring or both.
Okay.
Then the
Is
rest
that,
of the,
if I may, I'm sorry to interrupt. Would that be your sleep apnea stuff?
that would be
Okay.
sleep apnea,
Okay, gotcha.
Snoring,
Right.
gasping, choking,
Okay.
odd puffing sounds
Okay.
that often emanate from the back of the throat. That's
okay.
what 99% of it is. Insomnia would be the next biggest category. Some people who have sleep apnea have insomnia.
Right.
But it's a difficulty falling and as I may have defined earlier, difficulty falling and staying asleep with a
Right.
functional problem. Restless legs, probably 15% of the people I see, of which some have
Okay.
sleep apnea.
Right.
Restless legs mostly at night, but it can happen earlier in the day and also during sleep. The neurologic types of excessive sleepiness disorders would be the next category.
Okay.
Narcolepsy
Right.
and hypersomnia. These are people that seem to get enough sleep at night, but they're desperately asleep all during the day as well.
Okay.
So people who might fall asleep driving or fall asleep at the
wow.
computer all the
Right,
time, even though
right.
they had a normal, seemingly normal night of sleep. The next biggest category, believe it or not, and this is true in Florida, especially the west coast of Florida, where we have the first and third biggest Medicare population
Right, okay.
of counties in the whole country. REM sleep behavior disorder. These are people who have active dreams. They're dreaming and they're moving while they're dreaming.
Sleepwalking, would that count as that?
Sleepwalking is a youthful diagnosis
Okay.
that goes away after the age of about 15.
Oh, wow, okay.
People who have REM sleep behavior disorder may walk in their sleep, but they often jump out of bed because they're afraid of something.
Oh, wow.
Or they hit the partner they're sleeping with.
Okay.
REM sleep behavior disorder is a very unusual in the whole country. When I lived in Ohio, I might have seen a person who had REM behavior disorder once every 6 months.
Oh, wow.
Here I see it once a week.
Okay.
That's how much, because it's an older
Wow.
population.
That's what my grandfather had. I remember my grandmother talking about that all the time. He would like yell, scream, and like be flailing and then hit
Exactly,
her by accident.
exactly.
Holy moly,
REM
that's what
sleep
he
behavior
had.
Disorder. And it's treatable.
Okay.
Unfortunately, people don't think to say something
Right.
about it. They think it's just a weirdness.
Yeah, right?
They don't realize it can be a treated
Oh, of
disorder.
course.
Shift work sleep disorder. I
Yeah.
had a lot of people in Cincinnati, where I
Right.
lived before, who had this. I don't see as many here,
Okay.
even though there are a lot of shift workers.
Right.
But that is a pretty common diagnosis around the country, and I see it still, but not quite as much as in
Okay.
Ohio. And finally, an interesting condition that's a circadian disorder called delayed sleep phase syndrome. Now, these are the
Never heard of
commonest
that.
presentation as a teenager.
Okay.
The parent brings them in. This son of mine, I can't drag him out of bed for love or money, and he always is on his cell phone or doing something at 3 a.m. I get in there, I wake him up. I mean, I think I'm waking him up, and he's still on his cell phone at 3, and he
Right.
tells me he can't sleep. Not that he won't, that he doesn't try,
Right.
he just can't.
Right.
Then I have to get him up at 7 to go to bed,
won't get up.
school for the bus, and he won't get up.
Okay.
Delayed sleep phase syndrome.
So that's not just being a teenager.
No, that's what the parent thinks it's
Right, that's what teenagers do.
And the teachers at the school think the parents are dysfunctional,
Right,
not
right.
getting the kid to sleep when they should be.
Holy smokes.
And it turns out it's 7% of the population have.
That's not
delayed-
insignificant.
No, that's not.
That's not
7% of
insignificant at all.
teenagers go
Right.
through this. And usually 3 to 4 of that 7% get rid of it by the age of 20. But in the whole course of their high school career,
smokes,
they may
right.
be affected by it.
Wow. And not really know what the
And
something's
high
going
school
wrong.
principals should know about it too.
Right.
But
Interesting.
everybody thinks, kids got to sleep problem, or the
Yeah,
parents
right.
don't know how to parent the kid.
It's a behavioral problem,
and
it's not.
it's just a neurologic circadian
Wow.
rhythm delay.
How about that? All right. So those of you out there, there may be hope.
All
Right.
of these are treatable, by the way.
Right, that's
All
awesome.
7 of the
All right,
diagnostic
good.
groups are treatable.
So hopefully none of those apply to you, but if they do, it may make sense now for you. I know as I started to learn about this and understanding, okay, now it makes sense of why I'm having trouble falling asleep or why I'm waking up, and then I can make action steps to fix that stuff. Well,
Exactly.
that was very interesting. I appreciate that.
And your insurance pays for it.
There you go. Right. So to kind of bring us to a point where we can give somebody, I like to give everybody action items. What would you say are your top 3 things, if you can make 3 or more, that people could start today that would help their sleep better?
So, okay, very good. Three things that would really help people sleep. Well, for one thing, to maintain a consistent schedule.
Right.
Because this is a common issue. And we do have this 20% of the workforce in the U.S. are shift workers.
Right.
That includes hospital personnel, truck drivers, pilots, people who have work in factories where there's a nighttime factory need. It's very interesting that shift work is so much a problem. Almost every shift worker has 2 different sleep schedules in a week.
That's nuts.
Isn't that
So you
terrible?
can't get on any kind of routine at all.
Can't get on a routine. So that's
Right.
probably the number one thing I would say. Try to maintain a similar schedule 7 days a week.
Okay, good.
And if you can't have it be a 7 day a week, the same exact schedule,
Right.
because you're a shift worker, at least have the first 3 or 4 hours the same
Okay,
7 days a week.
gotcha.
That still allows the shift worker to be with the family for
Right.
a lot of the waking
Right,
time.
okay, good.
A second important thing, if it is possible, to have a natural treatment would be having an exercise that you're doing
Okay.
regularly.
Okay.
And that probably got into one of your other Fess Up sessions. that
It
you
did,
had with
absolutely, yep.
the viewing audience.
That's right,
That
absolutely.
was very important for us. And I have to relate to how important it is. I myself tend to be a sedentary person a lot
Right.
of the time. Now we have computers and we have cell phones and we have Netflix and we have all kinds of reasons for being sedentary. But to have a 45-minute exercise period that you can do several days a week, aerobic and, for that matter, also
Okay.
weight resistance,
And you don't want to work out or exercise too close to bedtime, though, right?
that is a good idea, to have at least 2 hours
Okay.
between the time you last eat and last exercise and go to bed 2
Okay,
hours later.
okay, good.
That is important. And a third thing would be to, and this is sort of kind of an obvious thing, but
Right.
but people are so not willing to consider the obvious. The light exposure that we get, it should be reduced, and a regular routine of relaxation should be incorporated at least an hour before bedtime.
Okay.
So
Gotcha.
minimizing light and having a relaxing routine an hour before bedtime.
Okay, good.
So that relaxing routine could be prayer, it could be
Right.
meditation, it could be watching something with the light reduced
Okay,
or reading,
right.
but something calming an hour before bedtime.
All right. Well, those are 3 great things. I appreciate that. Well, this has all been excellent stuff and things that I hopefully our audience will take to heart and can utilize and make their lives better with better sleep as part of our Fess Up Food, Exercise, Stress, and Sleep platform. But I want to thank you very much, Dr. Scheer, for taking the time. And I want to thank our audience for joining us for another episode of Unprocessed Sugar. I hope you got a lot out of this. I know I say it almost every episode. I know I did. And hopefully there's things that you can institute into your own life to improve the quality of your health and your wellness. Thank you again for joining us on Unprocessed Sugar. Hi, I'm Dr. David Sugar, a doctor here in Florida, and thank you for joining us on our podcast. A quick note, this is for educational and general information purposes only. Listening to this podcast does not constitute a doctor-patient relationship, and please consult with your own healthcare provider before making any changes to your own care. If you are having a medical emergency, please call 911 or your local emergency number. Any items, tests, medications that we talk about or discuss are for information purposes only and are not an endorsement. Once again, thank you for joining us, and please see the website for the full disclosure and waiver. Thank you very much.